And in 5, 4, 3, 2, 1, start broadcast.
This web conference is brought to you by WorldLink Medical. We provide evidence-based CME accredited education in preventive medicine and age management with a focus on bioidentical hormones. Feel free to visit our website for additional information on course offering and dates for 2017. Hello, everyone. Thank you for joining us today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I will be moderating today's event. I would like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right corner of your screen, you should see a chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. This web conference is brought to you by WorldLink Medical. We provide evidence-based CME accredited education in preventive medicine and age management with a focus on bioidentical hormones. Feel free to visit our website for additional information on course offerings and dates for 2017. Dr. Neal Rouzier is a pioneer and recognized leader in the bioidentical hormone replacement field, treating more than 3,000 patients, almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of HRT, hormone replacement therapy. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It is my privilege to welcome Dr. Neal Rouzier for today's webinar from his hometown in Palm Springs, California. Hello, Neal.
Hi, Mary. Good morning. Hello, everyone. Another day in hell here in Palm Springs. It's supposed to be 79 degrees, intermittently cloudy, no wind, visibility 1,000 miles. So I wish to share that with everyone else. So today is a continuation of the first webinar. And in the first webinar, I introduced a class action lawsuit against Abbott and AbbVie. And the gist of the matter is that these plaintiffs' attorneys are going after the drug companies for inappropriate marketing, off-label use, and not advising both physicians and patients of the harm of testosterone. And I went through that and punched holes in their logic and the reasoning and their conclusions. I wish to do the same thing today. I'm not trying to scare physicians away from prescribing testosterone, but I want to make everyone aware of what they should be aware of when they do prescribe testosterone, and that's really my purpose and my intent. My intent is to provide practitioners with the insight that I'm not able to provide in the courses that I teach, but this is information I think that everyone needs to be aware of that is not really available for most practitioners when they prescribe testosterone. It's not in any medical journal, it's not really in any course, it's not in any textbook, but I think it's information that needs to be known and understood. I will in turn try to rebut these comments from these couple cases that I'm going to present. And then in webinar number 3, I will look at all of the medical literature and support that testosterone does not cause blood clots, does not cause heart attacks, DVTs, PEs. I will then look at, in webinar 4, all the medical literature that states that we should be prescribing testosterone to treat symptoms and to improve health and wellness in spite of the fact that patients are still going to have blood tests that are in the normal range. The medical community, zealots, the FDA, AACE are trying to paint us into a corner and make claims that we should not be prescribing testosterone. Their goal is to restrict the use of it such that almost no one gets it. Their goal is to restrict the use of it so that patients that would really benefit from it do not get it. The reasoning I will not go into in great detail, but it's just the politics and economics of the FDA, unfortunately, that's something that we have to deal with. So this is another case whereby the use of testosterone was claimed to cause harm in an individual that developed blood clots. So the plaintiff's experts in this case want to come back to this term standard of care. And what is the standard of care in prescribing testosterone to patients? The standard of care is not written down anywhere. And of course, I will ask plaintiffs' attorneys and their experts, where does it state the standard of care? And of course, they're going to respond, well, the standard of care is just something that's gleaned with experience. Well, that's not evidence-based. So this case is Mr. E, a 40-year-old male who reported to Dr. R feeling tired and poorly, typical symptoms of andropause. What confused this case was that the plaintiff's attorney says that Mr. E did not qualify for receiving a prescription for testosterone. He did not have symptoms of low testosterone, and they all want to base their entire treatment on numbers, not on symptoms, but on numbers. This patient weighed 350 pounds, certainly would qualify for the beneficial effects of testosterone as far as weight loss is concerned, but they did not keep that in mind. All they looked at was blood tests. In 2014, the blood test results of Mr. E for total and free testosterone were within the normal range. That's open to debate. What is normal? We will look at that in webinar number 4, what is normal, what's optimal, what we should shoot for, and how they try to restrict the use of it based on lab tests in the normal range. So this patient's total testosterone was 326, which was in the normal range of 300 to 1100. But you can see 326 is at the very bottom end of the range, which would be conducive to a person having significant symptoms of low testosterone, whereas the literature shows that, and this is a quote from the New England Journal of Medicine, experienced clinicians shoot for the upper range of optimal for a young adult, which would be 1100. So in spite of the fact that the patient's level was 326, the literature shows patients will improve and feel better and function better and have health benefits when their level is 1100, as opposed to keeping their level at 326, which is at the very bottom end of the range. Plaintiffs' experts claim that 326 was not low enough to require treatment. My opinion is, of course, this is exactly where patients will fall and derive significant benefit. This range of 300 is randomly picked. It is not necessarily evidence-based because the same labs using the same reagents and the same laboratory machines can have completely different ranges based on what that particular lab decides to use. It is a randomly picked number based on what the pathologists at that lab want to use. In addition, the free testosterone level was 66, the range being 50 to 210. Yes, it is within the normal range, but that's typically normal range for an 80-year-old man that's sick. The range is an average of a population of both well people and sick people. So this guy falls into this normal range, but this is typically where people are at the very bottom end of the range for older individuals that are ill. That's hardly a number that is going to be conducive to optimal health as well as symptomatic improvement. This lab test, according to plaintiff's expert, was interpreted to be low by Dr. E, and based on, it was Dr. R, and based on the symptoms, testosterone was prescribed by Dr. R. 1 year later, Mr. E suffered a trimalleolar ankle fracture requiring surgery and pinning and cast immobilization with non-weight bearing for at least 8 weeks. This patient weighed 350 pounds, had surgery, was immobilized in a cast, non-weight bearing. That in itself probably puts one at significant risk for a blood clot. This patient did not receive any Coumadin prophylaxis by the orthopedist that operated on this patient. The interesting part of this case is that The patient suffered a fracture, was admitted to the hospital by the orthopedist who pinned and casted the patient and sent them home on baby aspirin, even though he weighed 350 pounds and he was immobile. The physician that prescribed the testosterone did not have access to the patient because he did not admit the patient to the hospital. The hospital that admitted the patient was admitted by the orthopedist, and the physician that prescribed the testosterone had nothing to do with the admission or hospitalization and had really no say-so in the care of this patient. The orthopedist did not stop the testosterone, and this patient unfortunately suffered a complication of a PE as well as a DVT, and did not receive any prophylaxis by the orthopedist who admitted the patient. A month later, Mr. E suffers a DVT and a saddle pulmonary embolus and is readmitted to the hospital. There was no effort or decision to transfer the patient to a tertiary care center for embolectomy or treatment of the saddle pulmonary embolus. In my hospital, we would have gone in and done an embolectomy immediately, and patient probably would have been treated with TPA before we were able to do that. This patient was not treated that way. They were not sent to a tertiary care center, and I really feel that the doctors that admitted this patient to the hospital and watched this patient for 3 days are at fault for not correctly treating this patient. TPA was not given, only heparin. Heparin is not going to dissolve the clot. It will only make the clot not propagate. The correct treatment for this patient would be emergency embolectomy and TPA. None of that was given. On day 3 of admission, unfortunately, Mr. E suffers a cardiac arrest and dies. Mrs. E files suit against the doctor, claiming that the testosterone caused the blood clot and that the testosterone should have been stopped before surgery, knowing that testosterone increases the risk of blood clot. What caused the blood clot in this patient was immobilization, weight of 350 pounds, and lack of prophylaxis. I will claim that the testosterone does not increase the risk of blood clot. However, plaintiff's expert will argue, it says it in the PDR, that it does increase the risk of blood clot. I went through that last time. Let me go through it again. Once a side effect is reported to the FDA, it's the FDA's responsibility to list it in the package insert and the PDR as a possible complication. That doesn't necessarily mean the medical studies show that, but once someone reports it to the FDA is obliged to report it and document it, and that's what they did by reporting it in the PDR. Their job is done. You cannot go back and criticize the FDA for not doing it. Once they do it, the information is there. But unfortunately, the science may not necessarily be there. There was one physician, Dr. Glueck, who has published several studies in medical journals showing that in a patient subset of those that have a thrombophilia or factor V Leiden and were prescribed testosterone, that they develop blood clots. That is an observation study. It does not prove causation. And when you look at the rebuttals to his papers, they will all state and claim the observation does not prove causation. It's a neat observation, but he handpicked selectively patients with factor V Leiden that developed blood clots, and they took testosterone. They got blood clots, so that's what they do. They get blood clots. I have a collection of patients. Rob also has a collection of patients that we'll look at his group next time. And in these patient population that we have treated with testosterone that have factor V Leiden, they have not suffered any complications or PE or DVT. We can therefore claim that testosterone protects against the development of blood clots. Well, no, we can't do that either because, again, that's an observation. It does not prove causation, and looking at an observation is worthless. You really need to look at studying large groups. I will show in webinar 3 that in all of these randomized controlled trials that are large studies and meta-analysis of randomized controlled trials, even with patients with congenital thrombophilias, we do not see any increase in DVTs or PEs in any of these studies. That is the gold standard, a randomized controlled trial, and when you've got dozens of these studies in meta-analyses that show no increase in blood clots, the science shows no increase in blood clots. Just because one person reports it, just because it states it in the PDR, does not mean that the science shows that it does. However, you can see where the plaintiff's attorneys are going to jump on this and say, it says it right here in the PDR. Well, it doesn't tell you in the PDR what to do about it, but the plaintiff's attorney is going to claim, well, the standard of care, but there is no standard of care. The standard of care shows what we should be doing based on the scientific evidence and literature. And this literature does not show that we need to stop testosterone or that it causes an increase in blood clots. However, the plaintiff's attorneys are claiming that testosterone should have been stopped before the surgery, knowing that testosterone increases the risk of blood clots. That's their claim. Neither the orthopedist, the internist, or the pulmonologist were sued in this case. Only Dr. R, who prescribed the testosterone, is being sued. It's sort of odd that the people that were really at fault in this case, the internist, the orthopedist, the pulmonologist, all should have given prophylaxis after surgery or sent this person to a tertiary care center and have an embolectomy. None of that was done. That really was, in my opinion, what caused this person's death, not prescribing testosterone. They really go after the wrong doctors in this case. And the one that really should not have had anything to do with it is the one that prescribed the testosterone, Dr. R, and he's the one that's being sued. They completely went after the wrong people. According to plaintiff expert, the standard of care for doctors of family medicine and doctors of internal medicine is the same with respect to treating patients for low testosterone, and this is their claim. Standard of care requires doctors treating a patient to only prescribe testosterone in accordance with FDA-approved use. The FDA-approved use is for hypogonadism, symptoms, and 2 total testosterone levels less than 300. If the patient does not fit into that category, then under FDA guidelines for FDA approval, the patient does not fit a diagnosis of hypogonadism. That does not mean that you cannot prescribe it. It doesn't say anywhere that you can't prescribe it. To treat men suffering from low testosterone only, and Mr. E was not suffering from low testosterone. Based on what? He was feeling poorly, weak, fatigued, and he actually had a weight increase from 250 to 350 pounds over a period of 2 years. And they're claiming that that's not a symptom of low testosterone, and he would not have benefited by it. And I will show all the obesity literature that supports the use of testosterone in treating obesity resulting in weight loss, and all of these patients that are treated have normal testosterone levels. They do not fall into this hypogonadism category that is a restrictive category intentionally restricted by the FDA to try to discourage the use of it. That in no way, however, prevents us from prescribing testosterone for off-label use. 95% of men that are prescribed testosterone have it prescribed for off-label use, meaning that they're prescribed based on the need to treat symptoms and not restrict them based on a number. Only 5% of men prescribed testosterone fall into that category of having levels less than 300. And they also claim that Dr. R should have discontinued the use of testosterone after ankle surgery, which required immobilization. But unfortunately, Dr. R had nothing to do with the surgery or any of his treatment afterwards, but they're claiming that he should have, whereas he had nothing to do with it because he didn't know what was going on. So they, again, have got the wrong people. Testosterone injections place patients at an increased risk of blood clotting. That's their claim. And pre-existing medical conditions like obesity and varicose veins, as well as surgical procedures requiring immobilization, can exacerbate this inherent risk of testosterone. My opinion is it does not exacerbate the inherent risk of testosterone. There is no risk of testosterone in any study, except the report from GLUEC. It should not have been stopped, but they claim that it should have been stopped, but it was not. The pre-existing medical conditions like obesity are going to be adequately treated with testosterone. It doesn't make it worse, but you can see where they can make argument and claim. Plaintiff's expert states that he is also familiar with several peer-reviewed articles regarding the risk of blood clots associated with testosterone therapy. Which ones? I've searched the literature. GLUEC is the only one that has published studies. All the other studies that are randomized controlled trials published in all these journals, and we'll look at those studies in the next webinars, do not show any risk of testosterone therapy, There's no increased risk of DVT, MI, or DVT in all of these randomized controlled trials that are much more powerful studies than just simply an observation. But, of course, plaintiffs' experts want to make all of the claim based on an observation study that's extremely weak and extremely flawed and ignore all the other medical studies to show no increased harm. And that's exactly how I argue this case as I have with others. Precautions. Patients such as Mr. E who are not suffering from low testosterone should not have testosterone prescribed to them, states plaintiffs' experts. In other words, feeling poorly, weak, and weighing 350 pounds does not constitute the need for testosterone. Really? That's their opinion. Their opinion is based on restrictive guidelines that state that it should not be prescribed if your level is greater than 300. You have to go back and look at those guidelines. What do the guidelines state? The guidelines emphatically state that we suggest, we recommend. It doesn't say it's illegal. It doesn't say you cannot. It doesn't state that you should not. It simply states we suggest. That's it. Those are the guidelines, and it is only a guideline. It is not a hard and fast rule, but they want to make it such. If a physician prescribes testosterone, the standard of care, there is no standard of care. His standard of care requires that the doctor prescribes the correct dose of testosterone and to take significant precautions against blood clotting. Well, this is where you get into this argument of just because it states it in the PDR does not mean that it causes it, and you have to understand why it states it and to be able to argue that fact. We also recommended that the correct dose of testosterone was not administered. The dose that he had was completely appropriate. These precautions include a complete cessation of testosterone therapy during the period of lower extremity immobilization. So the conclusion here is anytime someone's on testosterone and they undergo surgery, that you have to stop it. Anytime that someone is on testosterone, you have to make or take significant precautions against blood clotting. Like what? Prescribe Coumadin to everyone? There is a risk of blood clotting with oral estrogen. There's a risk of blood clotting with birth control pills. Do we make precautions against blood clotting for the millions of women that take birth control pills and oral estrogen? No. Do we suggest that they take aspirin or Coumadin? No. But there's an increased risk. Yeah, there is. We know it. It's documented. But do we do anything? No. Why? Because the harm of doing it would be worse than the benefit gained from treating them. Mr. E did not have low testosterone based on plaintiff's expert. Dr. R breached the standard of care by prescribing testosterone injections to Mr. E, and he did not need it because he did not have low testosterone levels. I will argue that he had significantly low testosterone levels, and I will also argue that levels have actually nothing to do with symptomatic improvement. I will show 20 articles in the literature showing that men that get testosterone will have a significant weight loss, which will affect their risk of heart attacks, strokes, and dying sooner. But plaintiff's experts claim he did not suffer from low testosterone because his blood levels were within the normal reference range. This is a red flag. So my suggestions to everyone that prescribes testosterone for, quote, off-label use is that you document the reason that you're using it. And the reason that you're using it is to help improve symptoms, health, and wellness, in spite of the fact that the blood tests are within the normal reference range. I will also include the articles that show that patients within the normal reference range will benefit from testosterone replacement. They don't have to fit into this below the normal range in order to provide an experienced benefit. Plaintiff's experts claims needlessly prescribing testosterone therapy, which carries inherent risk of blood clots and pulmonary embolus, is a breach of the standard of care governing Dr. R in his treatment of Mr. E. I completely disagree with that. Unfortunately, none of the doctors that are seeing Mr. E have done anything to help him lose weight and to decrease the visceral fat, to decrease his dyslipidemia, and to help improve his symptoms. None of the doctors have done anything for that whatsoever except for Dr. R. And unfortunately, Dr. R is now being singled out as the one that's causing the harm, whereas he was the only one that stepped in to really result in any benefit for treating this patient. I think the standard of care is to treat the patient, help him lose the weight, get the visceral fat down, and help improve his symptoms and help decrease his heart disease risk. But that's a different opinion of plaintiff's experts, and you need to understand how and why they can argue their point. You just need to document well that you disagree and why. Dr. R's breach exposed Mr. E to an unnecessary increased risk of blood clotting and pulmonary embolism, particularly in light of Mr. E's obesity and weight of 350 pounds. I find this case and all the cases around it just absolutely thoroughly disgusting, but it's reality medicine, and we have to be able to defend ourselves and to document well as to why we do what we do, and use the medical literature and use the medical support and the medical data to show why we do it. It is safe and it's beneficial. It is not safe or beneficial to leave somebody at 350 pounds and obese and just let them die from cardiovascular disease. But you can understand how and why they go where they go. Mr. E did not need testosterone therapy to begin with due to his normal levels. Normal is not optimal, and the normal level where he was is conducive to symptomatology and early death. Dr. R prescribed too large a dose of testosterone at 200 milligrams per week. That's a standard dose that most people get. This guy weighed 350 pounds, and unfortunately probably should have benefited from 2 injections per week and not just 1. My point of contention was the dose was too low. Their point of contention is the dose is too high. You can argue that back and forth. I will just show the literature where the standard dose is 200 milligrams per week, and probably with this gentleman's weight, he should have been given more. Dr. R also exacerbated his initial breaches by presenting too large a dose of testosterone, by prescribing too large of a dose. It's a standard dose that this patient got. A weekly 200 milligram dose of testosterone is large, even for a man whose testosterone levels fall outside the low end of the normal range. Again, I will argue this. They have no data to support that it's too high of a dose. I have all the data to support it is a standard average dose. And actually, he probably should have been prescribed more. Dr. R's prescription of testosterone to a patient who did not need testosterone directly and proximately caused an increased risk of blood clots and pulmonary embolism. No study shows or supports that. What the plaintiff's expert also included in this, which I did not, was what I included in the first webinar, that testosterone increases hematocrit and thick blood. We've argued that. I've given a webinar on it. And their point of contention was that testosterone caused an increase in hemoglobin and hematocrit. This patient's hemoglobin and hematocrit was at the upper range of normal for that lab. It was not elevated, it was normal. But they're still claiming that testosterone increases thick blood, and they've extrapolated that. They've assumed that since it does, that's what caused this patient's pulmonary embolism. I will argue successfully. Blood tests were normal, and erythrocytosis does not increase the risk of blood clots or pulmonary embolus, and we'll look at that in webinar number 4. There's a dozen studies out there showing that testosterone does cause erythrocytosis, but these studies also prove that the erythrocytosis has not caused an increase in blood clots, DVTs, PEs, heart attacks, or strokes in any randomized controlled trial to date, in any of the literature in 50 years. That's what you have to use to support your claim. You can't come up with an extrapolation of, well, because it caused thick blood, it caused the blood clot. That's an extrapolation and an assumption that is not true, that I will argue successfully against. Prescribing an excessive dose of testosterone directly and proximately causes an increased risk of blood clots. No, it doesn't. But I suppose where I would be concerned in this point in time is if you did a blood test and the blood test shows that your testosterone level is high, you can see where they can argue against you. This patient did not have a blood test that showed that his results were excessively high. But if you do have blood tests that show that, you may then want to repeat the blood test and test the blood at a time when you know the level is going to be low, and you can then show that the patient did not have a high level of testosterone. That's how to play the game. Unfortunately, I test levels to show and see that they're optimal and that they're high enough. However, plaintiffs will argue the blood test showed that the level was too high and that it should have been lowered. You can see where they will now again use this number. There's good reports in the literature that even though the testosterone level is supraphysiologic, the doses should not be altered if patients improve symptomatically, their health improves, they're not suffering any side effects, problems, or complications, and we don't see any of that in any study where they looked at supraphysiologic levels. Dr. R knew that Mr. E had at least 2 significant risk factors for developing blood clots, obesity and varicose veins, and as a result, the patient should not have been prescribed testosterone. I will argue just the opposite. Because of his obesity, testosterone is probably going to be one of the only things that this patient is going to benefit from. Dr. R's breach exposed Mr. E to an unnecessary and impermissibly increased risk of blood clotting and pulmonary embolism. I will argue the opposite. Plaintiff's experts will say it says it right here in the PDR. I will explain why it says it in the PDR, but when you look at all the randomized controlled trials, which is our science, it does not show that. No reasonably prudent physician in Dr. R's position would have prescribed testosterone therapy to a patient exhibiting Mr. E's comorbidities. I completely disagree. To leave Mr. E with a weight of 350 pounds, his dyslipidemia, his risk of diabetes, and his symptomatology and inability to exercise or do any sort of activity puts this patient at great risk, and testosterone was his only therapy that would have benefited this patient. Dr. R was the only one that really stepped in to help this patient, and unfortunately, he's being blamed for causing the harm. So, in conclusion, Dr. R exacerbated his original breaches of standard of care by failing to implement more effective prophylaxis against thrombosis He didn't discontinue testosterone therapy during immobilization. I see no recommendation in the medical literature or in the PDR that it says you need to discontinue testosterone because it increases blood clots during immobilization. That he did not administer the heparin-based blood thinner or Coumadin in this patient that was immobilized. Dr. R had nothing to do with this patient when he was admitted to the hospital and had surgery. It's completely the orthopedist's responsibility to prescribe heparin or warfarin for DVT-PE prophylaxis. Administering appropriate Coumadin in conjunction with testosterone injections, I never do that. I never see that it's recommended in the medical literature that we do that or in any study that we should do that. Dr. R did prescribe a baby aspirin as a blood thinner. Well, actually, he didn't. That was the orthopedist that did that. The orthopedist prescribed the aspirin, not Dr. R. The orthopedist should have prescribed Coumadin. Dr. R failed to prescribe a stronger prophylactic measure against blood clotting. I would not prescribe it. It's the orthopedist's responsibility to prescribe the Coumadin. And nowhere in the literature does it say that we should prescribe Coumadin when we prescribe testosterone. It does not say that anywhere. Dr. R also breached standard of care by failing to order Mr. E to discontinue or significantly reduce the dose of testosterone therapy when he was having ankle surgery. If there's a medicine that should be discontinued, it's the orthopedist's responsibility. Dr. R had nothing to do with the admission, surgery, or post-treatment prophylaxis in this patient. And I still would not have reduced the dose or changed the testosterone, which does not show any increased risk in any patient in any study. Mr. E's ankle surgery and his immobilization elevated his risk of blood clots. It definitely did. And the risk of pulmonary embolism. It definitely did. But testosterone has nothing to do with that. Coumadinization is what should have been done, and it was not. And then once the patient developed a blood clot, the appropriate treatment for that blood clot was not instituted. It has nothing to do with the testosterone. Testosterone therapy further elevated Mr. E's risk. And now you see how we need to protect ourselves because plaintiff's experts will come after us claiming that we should have done this, and this, based on standard of care that does not exist. But you can see how you have to argue this. And I'm trying to make everyone not be in a position to have to go through this process. Dr. R should have known that the morbid obesity increased Mr. E's risk of blood clots. Yes, it does increase the risk of blood clots, and that's why we're trying to reduce his obesity. It's the obesity that causes the increased risk of blood clots, not the testosterone. Dr. R prescribed testosterone injections to Mr. E even though he did not suffer from low testosterone. That's sad, humorous, funny, and just terrible at the same time, that the therapy that's going to benefit this patient the most, only Dr. R prescribed, and yet he's the one that's suffering the consequences of having to defend it. Everyone else didn't do anything. They would have just let the patient die. Dr. R should have known the FDA restrictions for prescribing testosterone products. What are the FDA restrictions? Please show me those restrictions. There's no restrictions. It says we suggest, we recommend. That's it. There are no restrictions. When the plaintiff's experts claim that, they're lying. There are no restrictions. Please show me where it says restriction. It says suggest, recommend. That is not a restriction. There are no restrictions. There's guidelines. That's it. Failing to properly interpret Mr. E's blood test, I think the blood test was interpreted extremely appropriately. The body does not look at, well, the level's 326, we must be fine, versus, well, the level's 300, now we're going to have side effects or symptoms. The body does not look at that, and those levels will fluctuate throughout the day. But you can see how they're wanting to use this number to make claim. You should, in turn, document the patient is prescribed it in spite of normal lab tests, because all the literature supports patients will benefit symptomatically and health-wise when we optimize their level, no matter what their baseline level is. Inappropriately prescribing testosterone injections when Mr. E was obese, that's particularly when you need it, and the obesity literature is full of data and studies showing how beneficial it is for treating obese patients. Failing to discontinue testosterone therapy when Mr. E broke his ankle, there's no evidence, support, literature, documentation anywhere that we need to do that, or that there's an increased risk of blood clots when somebody is immobile on testosterone. Failing to discontinue testosterone therapy after Mr. E had ankle surgery, there's no standard of care, there's no evidence, there's no data to support that there's an increased risk or that we should remove the testosterone. However, if you want to keep yourselves out of harm's way and you want to avoid having to go through this, my strong recommendation is anytime a patient has surgery, you discontinue the testosterone. Is there medical backup reasoning for that? No. As you well know, anytime you have surgery, the surgeon will tell you to discontinue aspirin products, any type of product that will increase bleeding, or any type of product that will increase risk of blood clots. Surgeons will tell women, if you're on oral estrogen or birth control pills, you have to stop those before your surgery. The reason for that is if you don't, and you get a blood clot, then somebody's going to blame you because you didn't stop it. So as a result, even though there's no evidence to support it, anytime a patient has surgery or is immobile, then my recommendation is to stop it, because if they have a blood clot, and even though the testosterone does not cause the blood clot, you and the testosterone will be blamed. Therefore, anytime I see or know of a patient and they call me and say, should we stop the testosterone? Should we stop the transdermal estrogen? Yes. Yeah, but there's no risk of it. Yeah, I know that. But if the patient does develop a blood clot, you will be blamed in spite of the fact that there is no increased risk. Dr. R failed to take and record the family history. No, he did record the family history. So did the orthopedist, so did all the other doctors. And there was no family history of any prior blood clots or thrombophilia. Dr. R inappropriately prescribed testosterone injections in violation of FDA-approved use. Violation? Well, this plaintiff's expert obviously does not understand off-label use, which is perfectly legal, and 95% of patients that are prescribed testosterone have it prescribed for off-label use. There is no violation of FDA-approved use. This guy's an idiot. But anyway, having said that, you can see where they will come up with these claims. Therefore, my advice is you document in your notes that even though the patient does not fall into the magical 300 number, and the level is greater than 300, you still prescribe the testosterone to help improve symptoms, wellness, quality of life, as is done in 95% of patients that are prescribed testosterone. There's no violation of FDA-approved use. Each act and omission, singularly or in combination with others, possibly caused Mr. E's death. I will argue against that. So what do we come away with in this case? Be careful, document well. If you have any situation or circumstance where the patient might develop a blood clot or be at risk for a blood clot, you need to seriously consider not using testosterone or discontinuing the use of it. Yes, but then the patient suffers. I know, it's the system. I'm just trying to protect you. Yeah, but then the patient suffers. I know. I'm sorry. I wish I could fix that. But my goal is to protect you. Unfortunately, the patient comes second. And it's the system, and that's the way the system is. Finally, hopefully, in 10 years, we won't have to deal with these issues. But for now, it's sort of on the front lines, and now you have plaintiffs, experts, and plaintiffs coming after you when you're trying to help the patient and you're being blamed for causing harm. This is the second case that I'm going to review. This is almost as disgusting as the first case. But this is a case in Texas where the clinics are being not only sued but also prosecuted for inappropriate false claims. So this gets back to what you are using in your internet advertisement or what you're using in your brochures or clinic advertisement. This is not good news. You're not going to like what I'm going to have to say. You're not going to like the outcomes. You're not going to like any of this, but hopefully it will explain what I'm trying to convey to you is be careful in your advertisement and be careful what you put out there. I am just as guilty as you. I am just as guilty as the clinics that make these claims for BHRT being safe. So let's go through this case and let's learn about what we can and cannot, what we should and what we should not state and claim. This case is brought by the state of Texas against clinics. Without waiving the objections, the state of Texas submits that to obtain restitution of the purchase price paid by consumers that bought bioidentical hormones from this clinic, the state's burden is to show that the Texas clinic defendants made misrepresentations and material omissions in its advertising messages that were widely disseminated and consumers subsequently purchased Texas Clinic's BHRT products. Their claim is that patients purchased these products because they were misled and misrepresented as to the benefits of BHRT products. Texas Clinic made material misrepresentation by falsely claiming that BHRT was completely safe, had no or minimal side effects, restored a user's hormone levels back to the levels of their prime, and that they used an FDA-approved compounding pharmacy to supply its hormone pellets. All of which are claims that probably should not have not been made publicly because they're not FDA-approved claims. If the case is not resolved on the basis of these material misrepresentations and omissions, the expert testimonies from their doctors will be used to show that the Texas Clinic defendants made material misrepresentations and omissions in their advertising. As we looked at in the first webinar, you cannot make, claim, or advertise anything on the internet or publicly that is not FDA approved. They have hired these experts that all have backgrounds from the drug industry, and they're all professors and academicians, and they have testified that these misrepresentations and omissions should be punished. These include the express substantiation level claims identified in the state's second amended complaint that Texas Clinic's BHRT is safe, involves no cancer risk for consumers. That's the claim that they made. It protects against cancer, another claim that they made. Is safer than and is not associated with the side effects, problems, and complications of traditional hormone replacement therapy. That BHRT generally prevents, treats, or cures disease or conditions associated with aging. In other words, it was anti-aging. Don't use that term. And that it reverses the effects of aging. Hormones do not reverse aging, and they're not FDA approved for anti-aging. You should not and cannot make those claims. They also made claims that BHRT protects against various cardiovascular problems, MI and strokes, and that it reduces cholesterol or can be used to prevent, treat, or cure high cholesterol. Yes, it does. Almost every study shows that it does, but you cannot make those claims publicly. Yeah, but then the patients don't understand it, and the public doesn't know or understand it. Yep, you're absolutely right. But you cannot make those claims because it's not FDA approved. BHRT treats, prevents, or cures Alzheimer's disease or memory loss. Well, all the studies show that both testosterone and estrogen protect against Alzheimer's disease, but it's not FDA approved for that, and therefore you cannot and should not make those claims. We know that it helps improve memory. Every study shows that. You can't make those claims. It prevents, treats, or cures diabetes. We know the effect it has on blood sugar. Estrogen decreases carbohydrate markers, and so does testosterone, so does thyroid. But you cannot make those claims publicly. That it treats, prevents, or cures depression or operates as a safer alternative to FDA-approved antidepressants, and with the same efficacy. Well, we see all hormones help to improve and reverse depression, but you cannot make those claims. You can only make those claims for antidepressants. BHRT can be used to treat, prevent, or cure arthritis or joint aches or stiffness, and it promotes weight loss. Well, we see that it helps weight loss, but you cannot make those claims. But then the patients don't know or understand that. You're right. Well, then how does the patient get to know and understand it? You have to explain it to them in person, but you cannot make those claims publicly. You can show them the articles in your clinic. You can give them brochures. You can give them books, but you cannot promote it publicly. When you do, you violate FDA standards. The opinions of the experts in this case concerning defendants' other misrepresentations and omissions includes supporting documentation or citations are contained in their expert reports and disclosures. So what these experts have done is gone back and quoted what the medical literature says and what the PDR says as far as hormones. The material misrepresentations will also be shown. The wide dissemination of the advertising containing material misrepresents what the FDA shows in the PDR, and their advertising containing material has misrepresentations and omissions that will also be shown. So right now, all of you are sitting there writing out, well, what can we say? Can we say this? Can we say that? You can. You can show anything that you want. You can use anything you want to advertise. But when you're called to court and the experts will testify against you that the FDA says you cannot and should not say this, and it says it in the PDR, all of the harms, you have misrepresented hormones. Yeah, but the articles in the study state, yes, I know that. Can you use those articles? You can use those articles. You can do anything that you want. But if anything that you put up there publicly misrepresents what you do, then you cannot and should not do it. Well, then what can you state? You can state what it is FDA approved for. Estrogen is FDA approved for treating menopause. Testosterone is FDA approved in men to treat hypogonadism. Thyroid is FDA approved to treat hypothyroidism. That's it. That's all you can say. That's all you can show. Yeah, but what about the patient not understanding the benefits? Sorry, you cannot say that. You can't state it. But can we use papers and articles to show benefit? you can, in your office, give those papers to patients. But if you put them up in your websites and you advertise it, you are essentially using misrepresentation of something that is not FDA approved for. The state plans to use the testimony of doctors X, Y, and Z to speak to the consequences of unsubstantiated claims, including those asserting safety, no cancer risk, no or minimal side effects, restoring to prime levels, and claims that they treat and prevent various diseases. You cannot and should not make or state those claims. We'll see what the PDR says about bioidentical hormones. The state plans to use the expert testimony to speak the likelihood of health risk and side effects of BHRT, and they will use the health risk and side effects of the synthetic HRT that's listed in the PDR. Unfortunately, the legal definition of a deceptive act or practice is one that causes or ends to cause a consumer to believe what is false or that misleads or tends to mislead a consumer as to a matter of fact. Translation: if you put up anything publicly that will mislead or cause the patient to think that something is better than something else, then you are guilty of fraud. Further, deception includes unsubstantiated advertising claims. I know what the papers and literature state. Can you use that? Yes, you can, but I'm not going to come defend you in court because what you said is misleading. Yes, but the articles state, I know the articles state, but if you put it up there, then the patient will interpret that what you are using and what you're prescribing is safe, and you cannot and should not do that. Without waiving the objections of Dr. X, Dr. X believes that any kind of advertising for prescription drugs, given the potential risk and side effects, should be subject to the same level of scrutiny that the panel of licensed medical experts at the FDA applies to pharmaceutical drugs. So, you have to then claim the same identical harms, potential complications to BHRT that synthetic HRT also has. Without waiving the objections, Dr. Y submits that the physician's desk reference does not have an entry for bioidentical hormone replacement, and as a result, you cannot make claims to compounded bioidentical hormones. In addition, the physician's desk reference is a compilation of the package inserts for all FDA-approved drugs, including certain bioidentical hormones like estrase and prometrium. If you go to the PDR and you look up Heparin and estrase, the verbiage is identical. If you go to the PDR and look up prometrium or micronized progesterone and Provera, the verbiage is absolutely identical. In spite of the fact that the literature shows and supports that micronized progesterone is much safer than Provera, the PDR does not state that. And you cannot state or claim anything in your advertisement that's any different than what it says in the PDR. Yes, but all the studies show. I know and understand that. But if you don't tell the patients that, then they won't know or understand. You are absolutely right. Well, that's not fair. You're right. It is not fair. But what I'm trying to do is to keep you out of trouble. And I'm guilty of this. I have looked at 1,000 different websites. I have not seen one website that does not falsely make claims to BHRT. Every single solitary one, including my own, is guilty of that. So, yes, I have to go back and completely redo mine. And yes, you should redo yours. Does that mean that the states are going to come after you? No. There's a million BHRT clinics out there. Do you think that they're going to come after each and every doctor? No. But if you're that one, you're completely indefensible. Well, then what can we say? I already told you what you could say. You can say exactly what it says in the PDR. The package inserts for estrase and prometrium do contain black box warnings. Read it. See what it says. They are absolutely identical. The adverse effects, the warnings, the contraindications, the drug interactions, and all of the information about the drugs is the same for Provera and prometrium, for estrase and Heparin. The FDA has also not approved the use of testosterone in women, so therefore you cannot make claims that testosterone does anything in women. For men, you can make claims. The claims you can make in men are that it is FDA approved for treating hypogonadism. That's all you can claim. The package inserts for estrace and prometrium are included along with this affidavit. The PDR contains numerous possible side effects for estradiol or estrace, which is bioidentical estradiol. And those risks are heart attacks, strokes, blood clots, endometrial hyperplasia, and endometrial cancer. The endometrial cancer and hyperplasia I agree with. If you do not oppose it with adequate progesterone, you will develop those problems and potentially endometrial cancer. I agree with that. I have seen many patients come to me on bioidentical hormones that are on progesterone creams and have endometrial hyperplasia and endometrial cancer. That's one of the studies I want to publish. If you do not use enough progesterone, that's what will happen. So therefore, you cannot claim that it doesn't cause cancer. Well, it doesn't cause breast cancer. I know that. But it could potentially cause endometrial cancer, and you're claiming that it doesn't. It does. I will argue the heart attack, strokes, and blood clots. I don't find any study with estradiol that increases the risk of blood clots, strokes, or heart attacks. Premarin, yes. We see that in almost every study. What about estradiol? No, we don't see that. Transdermal estradiol has not been shown to cause blood clots, strokes, or heart attacks in any study that I'm aware of. Prometrium is bioidentical progesterone. We all use prometrium to protect against uterine cancer and breast cancer. But it says it right there in the PDR. Prometrium increases the risk of breast cancer, heart attack, strokes, and blood clots. The risk of increased DVT with Provera is double or triple that of Premarin. In fact, it's even higher. The studies show that in the WHI and the HERS trial, when you added Provera onto Premarin, there's an increase in heart attacks and strokes 4 to 6 times over estrogen Premarin alone. As a result, there's all these contraindications and harm with Provera, but there's not a separate listing for Prometrium. It is identically the same as Provera. So when you read it, it's Provera, and you think, well, that's not right. I know it's not right, but that's what it says. And of course, testosterone replacement has not been approved for use in any women, and as a result, you cannot make any claims because it's not FDA approved for use in women. They go on to say Testapel, a subcutaneous bioidentical testosterone pellet approved for men, contains warning that accidental exposure to women. I don't know how a woman would be accidentally exposed to a pellet that's implanted in a man. But anyway, accidental exposure to women results in virilization, deepening of the voice, hirsutism, acne, clitoromegaly, and menstrual irregularities. So if you're going to make any claims about testosterone in women, you have to make the claims that this is a potential side effect of it. And you cannot make any claims as to what it does because it's not FDA approved for women, and you cannot make any claims whatsoever. But yet these clinics did. In the courses, I use probably over 100 studies showing benefit of testosterone in women. Minimal side effects, it's all dose-related, tremendous benefits. You cannot make or state those claims of all those studies. You can give the handouts in your clinic when the patient comes in, but you cannot publicly make those statements. The drug labels approved by the FDA for bioidentical hormone products include warnings about the possible side effects and health risk of estradiol and prometrium, and they are the same as Premarin and Provera. The FDA has not approved the use of testosterone replacement in women for any indication, so you cannot make any claims for any of these hormones. The representative package inserts for individual bioidentical hormones that have been approved by the FDA, like estrace and prometrium, and that state black box warnings, adverse effects, contraindications, and drug interactions, and other information about the drugs are attached. And indeed, when you read it, it's disgusting. All the literature shows we do not see that harm with prometrium or estrace. But it's listed, and you cannot make claims other than what's listed in the PDR, and that's FDA approved. Aside from labeling, the FDA stated that it is not aware of any credible scientific evidence to support claims made regarding the safety and effectiveness of compounded BHRT drugs, and that's absolutely true. Compounded drugs will never be studied, and they're all going to be different. So you cannot make claims about something which is not FDA approved, but everyone does based on the literature showing the benefit of bioidentical hormones. Those bioidenticals are FDA approved bioidenticals, and you cannot extrapolate to compounded. It's illegal to do so. Without waiving the objections, Dr. Y disagrees with the above proposition. The Texas Clinic's BHRT cocktail has not been studied, has not been evaluated by the FDA, and that is estrogen pellets, testosterone pellets, and micronized progesterone. The FDA's position is that hormone replacement consisting of bioidentical estrogen alone or bioidentical estrogen with progesterone has the same potential risk and benefits as synthetic estrogen and synthetic progestins. And you cannot make claims otherwise, and that's what they state. All estrogen products, whether synthetic or bioidentical, carry the same information about the health risk of heart attack, strokes, blood clots, endometrial hyperplasia, and endometrial cancer. All progesterone products, whether synthetic or bioidentical, all carry the same information about the health risk, which include an increased risk of breast cancer, heart attack, strokes, blood clots, just like the package insert says. I know that's disgusting. I know that's not true, but I'm just trying to get you not to have to defend yourself against making false claims. Don't make the claims. The FDA has not approved the use of testosterone replacement in women and has warned of the virilization side effects. That's all you can make claim to, nothing else. Okay, I hope that was informative and intentionally disgusting. And the reason for that is to try to teach you, show you, and help you how to protect yourselves and stay out of trouble. That's my goal of this lecture. Okay.
Yeah, Neal, can I interrupt for just a minute before we start a question? Sir? I just wanted to take a quick moment and to thank MedQuest Pharmacy for making this possible through an educational grant. We're grateful for the continued support and recognize the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. For those of you that have just joined us, if you look in the lower right-hand corner of your screen, you should see the question and answer box where you can enter your questions to Neal. Thank you, Neal. I'll turn it back over to you.
Thank you, Mary. Julie Grafmeyer writes, what is my opinion about providing patients letters of medical necessity for testosterone or other bioidentical hormones? You can provide letters of medical necessity if you're willing to defend it and hassle the insurance companies. The reason that they send you a letter is for you to make the medical necessity claim so that they can later go back and state that your claim is inappropriate. I do not do insurance claims. We have not done that for 10 years. We give a receipt to the patient stating that they can submit it to their insurance, but we will not fill out any insurance forms because, you know, that's like going down a gopher hole. You'll never get back out again. There'll be more claims, more papers, more paperwork. How many other prescriptions have you tried? Have you tried Provera? Have you tried this? You know, document the side effects. Send in your clinic notes where you've tried it. You will get down a rabbit's hole and you'll not be able to get back out. But you can make those claims. I don't, but you can. Remember when I say I can? When I say I can, that means you can, but I don't. Does this open up my practice to the insurance companies or any other legal matters? Yes, it does, because when you make these claims, you have to be able to support the claims, which is why we stopped making those claims. That paperwork is not for your benefit. That paperwork is labor intensive and not to be of your benefit. It's for the insurance company's benefit and not your benefit. And as a result, I don't deal with insurance companies and I don't deal with those claims. Sorry. Next question. This might be a dumb question. There's no dumb questions. But you are talking about men and testosterone. I'm assuming we cannot market any benefits of testosterone on women either. Improved energy, libido, sexual function. You are absolutely correct. You can market it, but you're not going to be able to back it up. And if you're called on the carpet, to show that it's FDA approved for those things. It is not FDA approved for those things. It is not FDA approved to improve energy or libido, and as a result, you should not and cannot make those claims. You can only make claims for what it is FDA approved. It's not FDA approved in women, no claims in women. It is FDA approved in men. The claims are, we treat hypogonadism based on FDA guidelines. That's the only claim that you can make. You can do it otherwise. You can use it off-label. You can explain that with off-labeled use, but you cannot advertise it as such. Dov Rand has flipped me a chart note that he sends out patients where he describes all of the health benefits to his patients based on the medical literature and based on those articles. I will give you a lot of those articles when we do webinar number 3 and number 4. But in his letters to his patients, he explains the benefits to the patients, and he explains by showing the medical literature and studies as to what the hormones do. Now, you can absolutely do that when you make claims to your patient in your letters, but you cannot advertise it publicly on the internet or in any brochure that is sent out publicly. But you can do anything you want in front of the patient in your office. I'm sure I just answered my own question. Yes, you did, but I will feel warm and squishy if you confirm this. Yes, I know. You know, I don't have any good news in this lecture. All I'm doing is trying to show you where people get into trouble and how to stay out of trouble. Yes, you want to be able to advertise that and attract patients and show them and educate them as to how this is going to help them and help their health and help their well-being based on the literature and the science. Yes, I understand you want to do that, but there's a force out there that's preventing you from doing so, and I want you to understand that force, because if you make these claims and you get called in the carpet, you will not be able to defend those claims. Kim Hansen asked, if testosterone is causing post-surgical clots, then how do you block testosterone in order to perform surgery on 18-year-old males? Well, good question. I like your sarcasm, but you have to understand that in 18-year-old males, they're not getting testosterone, so you don't need to block it. But in older men, when you're giving it to them, that's a different story than what you have naturally. I understand your point of contention, and I do like your sarcasm, but 18-year-old males that make it naturally are not equivalent to 65-year-old males that you're giving it to. It's when you give something to someone that it's causing harm, not what they have baseline in their system. But I like your thinking. No, you don't need to block testosterone. It's sort of interesting. I've read other commentaries that what these experts claim is that when you give testosterone to men, it increases estrogen. And when it increases estrogen, it causes the blood clots. Glueck also states that in his articles, that when you give testosterone, it raises estradiol. And we know that estradiol in women causes blood clots. I mean, you know, that makes me just want to scream and punch the wall. Raising estradiol transdermally does not cause blood clots. Raising estradiol naturally does not cause blood clots. Giving somebody oral estrogen that goes through first pass effect will increase blood clots with Premarin. We don't see it with estradiol. But what he's doing and what others are doing, and they're extrapolating, well, if you're raising estrogen in women, that causes blood clots, raising it in men is also going to cause blood clots. Well, if there's life on Earth, there must also be life on Mars. Well, there's not. Well, you assume that there is. No, you can't assume that there is. You have to prove it. And raising estradiol in men by giving them testosterone has not been shown to cause blood clots in any study. When we gave cholesterol to men, we did see an increase in blood clots, but we have not seen it in any study when we give estradiol to men. So again, you cannot and should not extrapolate. But you can see where they will make that leap of faith, but I will completely disprove that. But you can see it's just thoroughly amazing what these people confabulate, imagine, and concoct that is not based on science, but just based on confabulation. I guess that's the word that I want to use. Robert asks, is there any facet of testosterone therapy that may increase the risk of blood clot, such as elevated estradiol? Well, I guess I just answered that. There's a dozen studies where we give men estradiol, both orally as well as transdermally. Why would we do that? We do it when we treat prostate cancer. Any study show harm? Yes, with 5 milligrams DES. There was a study that showed giving 5 milligrams of DES caused blood clots. What about 1 milligram of DES? Nope, very safe. It was the high 5 milligram DES, which is equivalent to like 10 Premarin tablets. Well, goodness gracious, nobody would do that. But that's what the study showed, and therefore everyone thinks that, oh, raising estrogen in men causes it because the 5 milligram of DES caused it. Well, no, estradiol has not caused it in any study, and there's no study in 50 years when we raise estradiol by giving testosterone that it increases the risk of blood clots either. But they will make that leap and that claim that it does. But you have to show me a study where it does. You cannot make an assumption or an extrapolation. It does not cause an increase in blood clots. There's 20 or so studies when we block estrogen in men with aromatase inhibitors, and every study when we block it, it's harmful, and there's no study that shows when you block estradiol in men that it decreases blood clot risk. There are studies to show when you block estradiol that it dramatically increases dyslipidemia. It changes and makes lipoproteins worse. It lowers libido and sexual function. It increases diabetes and blood sugar. It also increases visceral fat and subcutaneous fat. So I don't block estradiol, I just leave it alone. Hi, Jeff. Dr. Zuckerman says that I use an optimal free testosterone for me between 40 to 60. That's LabCorp. I have some men on transdermal testosterone applied to the scrotum and need 400 to 800 milligrams per ml to achieve this range. What are my thoughts? Well, I typically don't have to go quite that high. My thoughts are, I've had 1 or 2 patients that I used a 200 milligram per gram dose, 1 gram, twice a day, and the levels were low. And the levels were so low that I thought, they're not doing it right or they're cheating, which they were, because I brought them into the clinic and I said, measure it. They either don't measure it correctly. It's 2 pumps. Apply it to the scrotum. They were sort of like slapping it on their inner thigh and not the scrotum. I said, no, apply it to the scrotum, rub it in like you're supposed to, sit around for 4 hours, and we test the levels. And everyone that I've tested that has done it correctly, I get great levels. So I do not think it's the harm of the testosterone not being absorbed correctly. It's user error or user cheating. Those are my thoughts. Robert asks, which patients should be treated with either HCG or Clomid versus testosterone itself? Anyone that wants to preserve fertility, anyone that's 40, 45 years of age that still wants to preserve fertility, should be treated with HCG or Clomid. If you're going to treat a younger man, and sometimes that is in older men too, because older men, 65 and 70, still want to father children. I have no clue or understanding as to why they would want to do that. But it is in the literature that they do. I would not use testosterone because it shuts down the production of sperm and testosterone when you knock out the HPA axis. So I use Clomid or HCG, and anyone that is willing to use it as a substitute to testosterone and wants to preserve fertility. Should a testosterone stimulation trial using either HCG or Clomid daily, 8 days before the lab testing? You can. I don't, but you definitely can. I give HCG and Clomid daily, and then I just test them. It doesn't make any difference when you test them, as long as you're taking it daily. And do you want to test for DHT? You can. I don't. Lowell Gerber from Maine just sent me a lab test where he measured the DHT level in somebody, and it was like over 1,000. And I asked him why he tested it, and he said, well, because they had acne when they were young, and he wanted to see what the DHT level looked like. Well, are they still having acne now? No. Any side effects? No. Do they feel good? Yeah. Sexual function improved? Yes. Feel pretty good otherwise? Yeah. No side effects? No. Then why do you want to do the DHT level? Well, because I want to know what it is. Okay, well then test it and then you're going to send me the lab result and say, should I treat it? And I'll say, I don't know. If I don't want to see what's on the other side of the door, I don't look on the other side of the door. If I don't want to see what the DHT level is, I don't test it. But you can test for it. Now that you've got his symptoms improved and the DHT level is higher, you're going to use a 5-alpha reductase. In part 4, we go through the side effects, problems, and complications of 5-alpha reductase inhibitors. You want to read it? Go ahead. I try not to use those. And if I use them, I really advise the patient of the potential side effects, problems, and complications of them as listed in the PDR. So again, you're going down a gopher hole that you're not going to get back out of. I don't test for DHT. I will test the testosterone. That's it. I don't test for FSH, LH, and estradiol. Why do you want to test for those things? Well, because I read somewhere. Then fine, go ahead. Then call them up and ask them, when you get those levels back, what they suggest. Well, they suggest blocking it. Well, when you block estradiol, we all know what happens. I don't block it. Dr. Gershon, thank you. Dr. Gershon's my PMD that's helped me out immensely with my medical problems and issues, and I can't thank Steve enough for doing so. When do you recommend to restart the testosterone after surgery? That they didn't need to stop in the first place. Well, I recommend that they restart it whenever they're out of danger, and I don't know when that is. So I guess when their immobilization is over with. I don't have an answer, but I like your sarcasm. But anytime the patient is then back to normal, I guess is the reason for then restarting it. When do you restart estrogen after surgery? Well, once they're back to getting up and moving about and they're no longer at risk for a DVT, PE, or whenever they stop their prophylaxis, I guess, is when you would want to restart the testosterone. Melissa asked, thanks, Dr. Rouzier. We cannot make these claims regarding the safety and efficacy of BHRT publicly. Can we still discuss candidly with our patients? Of course you can. You can discuss anything you want. You can give them anything you want. You can give them books. You can give them the brochures and booklets that we publish for your use. You can give them the books. You can give them other people's books. But you cannot publicly, in your marketing materials, particularly on the internet, use any of that information that I talked about. And you can see that the reason for not doing that is that the FDA is trying to prevent patients from being duped from unscrupulous claims of supplements, vitamins, hormones, magic potions, etc., of which many of them are. So it is a public protection mechanism that prohibits anyone from falsely attracting patients to buy a product that does not live up to any particular standards. That's the problem with vitamins and supplements, is that they are not regulated. It's sort of buyer beware. But for a drug, it falls into a different category that is FDA regulated, and as a result, you cannot make those statements publicly. Dr. Gerber asked, is estradiol still FDA approved for osteoporosis? Yeah, it is, Lowell. I failed to be complete in my statement. Estrogen is FDA approved for two reasons. Number one, treating symptoms of menopause. And number two, it is FDA approved for osteoporosis. It is FDA approved for preventing osteoporosis. It is not FDA approved for treating osteoporosis. So yes, you can state that we use estradiol to treat symptoms of menopause and to prevent osteoporosis. Lee Wolfer writes, just an FYI, apparently FDA is also going after use of desiccated thyroid and T3 formulations as part of this coordinated effort. Recommend docs document reasons for using desiccated thyroid and T3. I'm not aware of the FDA going after anyone. I mean, desiccated thyroid is, Armour thyroid, nature thyroid. It's an FDA-approved medicine for prescribing. You can get it and prescribe it through any regular pharmacy. I know that AACE doesn't like it and they market against it. But in part 4, I've come up with about a dozen studies and articles showing that desiccated thyroid does work better. There is evidence base for it, and there should not really be this motion or push against it based on all the studies to show that it does provide greater benefit. And these are randomized controlled trials that show benefit. But anyway, thanks for the FYI. I strongly advise you and encourage you not to make all of these claims as to what thyroid or T3 does. Even though it does help weight loss, it does help lower lipids, it does help improve all of these other symptoms, you just cannot make those claims. The FDA has indications for the use of drugs. However, practitioners can use the medication in question and market it if the data supports its efficacy. Well, that's what AbbVie and Abbott did. Was they showed all the medical studies and literature that showed benefit, but unfortunately now they're being the subject of a class action suit. You can use any medicine in question for off-label use. You do not have to use it for its only FDA-approved use. But the problem is in marketing it, and that's where Abbott and AbbVie got into trouble, was that they were marketing it for off-label use. They cannot and should not do that because it goes against FDA guidelines. They can only market it for FDA use, which was treatment of symptoms of hypogonadism, period. That's all you can and should say, and that's all that they could and should have said. But the marketers made exception to that rule by marketing to both patients on television ads, as well as marketing to physicians for off-label use. And unfortunately, the laws do not allow us to do so. Even though the data supports its efficacy, yes, you can. You can go ahead and do that. And that's what AbbVie tried to do. That's what the Texas clinics tried to do. They tried to market it based on the literature and science and studies that showed efficacy, but it wasn't FDA approved for that. And if you want to fight the battle and you want to spend $100,000 and the rest of your life trying to fight it, yes, you can do it. You absolutely can. But I don't, and I won't, and I don't suggest that you do, because I don't want to have to come defend you. For example, Botox is only FDA approved for glabella and crow's feet, but it's used all over the face. You're absolutely right. And peer-reviewed articles document the safety and efficacy. You are absolutely correct. And there's articles that show that the safety and efficacy of using bioidentical estrogen, and the safety of using bioidentical natural progesterone, and the safety and efficacy of using bioidentical testosterone. And there's articles that show the safety and efficacy of it. But based on FDA guidelines, you cannot market that. You can use it, you can discuss it, but when you market it publicly, you will be in trouble. The FDA is not the only entity that dictates the claims one can state on the web. It is the state medical board that determines the information that is considered misrepresented. Boy, did I fail to bring that up. It's really not the FDA that comes after you at first. The FDA can come after you, but that's usually class action. That's usually federal. That's big time. That's where the big boys play. Little boys like you and me, it's the medical boards. And the medical board will look at this. And it's the medical boards that scan the websites looking for anti-aging, age management, BHRT clinics, anything that has to do with catch-all phrases where they would come up and be able to look at a website for BHRT. They've got nothing better to do than sit there and do that. Oregon, Washington, Idaho. My recommendation is, if you advertise on the internet, that you don't. My recommendation is, if you prescribe BHRT, do not let your patients tell their peers or their private doctors. Because when the private doctors see it, they will send letters to the medical board, and the medical boards in those states investigate and evaluate everyone. The same thing applies to Midwestern states. I won't give you all the names because there's about 10 of them, And some of the southern states, too, around Florida and Georgia and Alabama, they're going through the same issue. It seems like it's a cancer that's spreading to the various states where the medical boards are going after people for this false claims. You know, there's doctors prescribing narcotics just randomly to everyone. Thousands of people are dying from overdoses. No big deal. It's okay to do that. But you advertise BHRT, we're going to get you. I don't know why this is. I don't understand the animosity, but it has to do with politics, economics, and your peers that do not like or understand what you do. So yes, it is the medical boards, and that's why I'm trying to keep everyone out of trouble. Jose RT asked, can you make a statement and have a disclaimer at the bottom in small print, the way that the big pharma does? Sure, absolutely. You can do that. You can make all the statements. You can make all the claims that you want. You can put all the small print down there that, you know, all the claims that you just made to try to mislead and misrepresent what you do, that it's not FDA approved. Yes, you absolutely can do that if you got my sarcasm. Yes, you can. I don't. I don't make recommendations, and I recommend that you do not make any recommendations or false misrepresentations that anyone can come back and criticize you no matter how much small print that you put at the bottom. But yes, you can. Kim Hansen again writes, I understand that you cannot make claims regarding uses that are not FDA approved. That's correct. However, when books are published, they discuss non-approved uses. Absolutely. Where's the fine line between education and advertising? I don't want you to find out where the fine line is because in order for you to find out what the fine line is, you're going to have the medical board knocking on your door and saying, okay, you've crossed over the line. And I don't want you to have to go through that. Once you see the patient, you can give them all the educational material that you want. But if you're advertising on the internet or sending out flyers or brochures to the public, that is where you're going to get into trouble, and that's where I ask you to use caution. And now you're saying, yes, but now we can't advertise. That's what I'm saying. Well, you can advertise that you do BHRT. You can advertise what happens when you lose hormones. You can advertise the symptomatology of when you lose hormones. You can then state that you prescribe hormones. You cannot make claims that you reverse all of those problems. You cannot make claims that any of the BHRT, what you prescribe, does anything. All you can do is state that you prescribe it. You can add anything else you want onto it. Be my guest. But I'm trying to get you to understand, and I've hoped by using the examples of AbbVie and Abbott, by using the examples of a couple of the cases where plaintiffs' attorneys are criticizing the use of testosterone for unapproved conditions, and this Texas clinic that is now having to defend itself by making all of these misrepresentations in advertisement. And I don't want you to have to go down that path. Well, then we can't advertise. I know. You can advertise that you do BHRT, and you can advertise the harm of hormone loss, but you cannot make claim that the hormones that you prescribe do anything. You can sort of make that statement that you prescribe hormones to help improve symptoms, but you cannot make claims as to which hormones you use or which hormones do anything. Lee Wolfer asks, so Institute of Functional Medicine and Heparin keep teaching that testosterone raises estradiol, which causes clots, heart attacks, strokes, dementia. Is your assertion that visceral fat is the issue, and perhaps documenting increased risk of clots in a morbidly obese male may have helped into this case? Well, yes. The more obese a patient is, the greater the risk of blood clots. And I disagree with raising testosterone, raising estradiol causes blood clots, heart attacks, strokes, and dementia, because I will show that lowering visceral fat by giving testosterone and raising estradiol decreases the risk of blood clots, heart attacks, strokes, and dementia. Yes, it is the visceral fat that is the issue, and that's what we're trying to knock down with the visceral fat, and you can do that with hormone replacement. There's even an article recently showing that melatonin helps to decrease insulin resistance and protect against diabetes. We don't see that with progesterone, but we see it with estradiol, thyroid, testosterone, and DHEA, as well as growth hormone. Kim Hansen asks, I have a physician in the area that uses AccuReference Lab, something other than LabCorp or Quest. How do I go about obtaining reference ranges that are based on your method of replacement versus what is regularly accepted? I don't know. I don't have an answer for you. You're going to ask the lab to give you the reference ranges and go from there. I don't have any other suggestions. You can take your labs, put age 18 on the lab slip, and send both male and female labs in to be evaluated with an age 18. Those reference ranges that you get will be that which is used by the lab. Again, those reference ranges are randomly picked by the pathologist and not based on any particular science. I want to be assured that the numbers there are being reported correlate with your teachings. They don't. I sort of emphasize this in the courses, and I continue to emphasize by showing the medical literature that shows that supraphysiologic levels of hormones, and that's all hormones, tend to result in improvement of symptomatology. When you're looking at numbers, it's a normal for an average age. It doesn't mean what's best. It doesn't mean where they're going to feel the best, where they're going to function the best, or where you're going to have the metabolic effects that are the best. It is basically an average of a population. If you're wanting to stay average, then don't prescribe hormones. If you want to see improvement of symptoms, then you have to go above that upper end of the range. There's a multitude of cases that I've reviewed where the plaintiff's experts claim that you should not have gone above that normal range. Whereas I present all the data that shows if you don't go above that upper end of normal, you're not going to result in any improvement of symptomatology or any health benefits unless you do so. So you get into this pissing contest as to numbers. And if you want to be in the safe side, then test your numbers and arrange to have the blood test done so that the numbers are still normal. You won't be able to see what optimal is, but you'll be able to show that you're still within the normal range. That will keep you safe. Hi, Lane. Lane writes, I wonder how disseminating real information via group seminars taught by practitioners in my pharmacy would be viewed by the FDA. I think that you can probably do that because what do I do in my courses? I do the same thing that you would do by teaching the practitioners. It's the advertisement to the patients that you need to understand. And that's what the FDA is trying to do, is to prevent misrepresentation and advertisement to patients that will attract them in to do a therapy that they feel is not evidence-based. Kelly Cook asked, would I use HCG with testosterone if the patient desires fertility? You can. If they really want to maintain fertility, then I would not use the testosterone. There's two studies in part 2 where I address this issue. One study shows that when you use testosterone, it will overcome the benefit of HCG and it will affect fertility. Another article shows that when you use testosterone and HCG, the HCG does not change or improve testicle size, but it does improve and change sperm counts. But just because you use HCG and raise sperm counts does not guarantee that they're going to be fertile if they're on testosterone, because you're still going to shut down that HPA axis. I don't mean HPA, that's adrenal axis. But you're going to shut down your feedback to the testes where you normally produce FSH and LH that stimulate the testes to produce testosterone and sperm. You're shutting that down completely, so you're shutting off production of sperm. So as a result, if you're really going to try to maintain fertility, then I would definitely stop the testosterone. I've used weekly testosterone injections with HCG on day 4 and 6 with good results on a few patients. That's fine. Yes, you can do that. The semen analysis, I've come back with adequate levels of sperm and motility. The studies show that, but there's also studies to show that it doesn't, and that testosterone is used as birth control. So it's sort of hard to put together, well, I'm using HCG to help improve fertility when you're using testosterone, which is used as birth control in men. So I'm just trying to keep you out of trouble, and I just had to defend such a case. Lee Wolfer asked, can you prognosticate on whether the FDA will continue to pursue this under the Trump administration? I have no idea. Lee writes, FDA specifically wants to push the use of Cytomel instead of T3 preps. I don't know. They may want to. Again, they're completely against desiccated thyroid. There's a religion against desiccated thyroid. It doesn't mean you can't use it. And I use it in all my patients. It doesn't mean you can't, just don't advertise it as such. Allison says, hi Neal, as far as advertising is concerned, what's my opinion if we were to advertise what estrogen, progesterone, and testosterone are FDA approved for? Yes, you can. But remember, testosterone is not FDA approved for use in women. And list the symptoms of menopause and hypogonadism. Yes, you can list the symptoms of a deficiency. You can list the symptoms of what happens when you lose it. And you can then state that estrogen, progesterone, and testosterone are FDA approved for treating menopause, and it's FDA approved for treating symptoms of hypogonadism. And that's all you can state and claim. You can't state or claim that it reverses or treats any of those symptoms that you've listed as symptoms of a deficiency. Rob writes, Ohio has lost its ever-loving minds. Yeah, I know. All I can say is move out of those states. I don't have any other better solution. I try to educate the medical boards, but the medical boards do not want to be educated. I've tried to educate a couple of the medical boards. Some of them listen and they understand and they say, wow, this is really, neat information that we didn't know about, and they took my education seriously. And there's some medical boards that just completely look away, yawn, and do not want to listen to what I'm trying to say or what I'm trying to show them. Those are the states you need to move away from. There's nothing you can do. You can't fight the battle. I don't know what else to say. I wish I could be more optimistic. Lee says, by the way, I agree with you, not Institute of Functional Medicine or AFRM. You've taught us well. Well, thank you very much. I try to use evidence-based medicine and literature to show what we should do and why we should do what we do. For all of you that have taken parts 1 through 4 and you've had patients that see improvement, I don't have to explain that to you. You understand and see what it does and why we use the evidence base. For those that are newbies that haven't gone down that path yet, hopefully you will go down that path and understand what we're talking about. Well, last webinar lasted 2 hours. This webinar lasted 1 hour and 40 minutes, so I guess I'm getting better at it. Hope it was fun and helpful. I hope that you go back and reevaluate your marketing material and your websites. I hope that you document well in your notes. I hope that you try to educate and show support to your patients as to why you do what you do, and just document well. That's the best advice I can give you. Webinar number 3, as Mary is going to tell us, is going to be on March 21st. Then probably webinar number 4 is going to be the second Tuesday of April, which will be the 11th. In both of those webinars, I'm going to do just a pure literature review of all the articles that you should have access to and in your armamentarium that you can use to hand out to patients. Thank you very much, everyone. Have a nice day. Mary and Dana and Chris, back to you. Thank you.
Thank you, Dr. Rouzier. I hope our listeners enjoyed it as much as I did. As Dr. Rouzier just said, webinar number 3 is going to be Tuesday, March 21st. It'll be 12 p.m. Mountain Standard Time, and then April 11th will be webinar number 4, and the time needs to be determined on that. We will let you know. You should also be receiving an email in the next 24 to 48 hours with the archived webinars for both today and last week's webinar, for those of you who've missed it or others who would like to share it. Thank you again, Dr. Rouzier, and everyone who joined us today. Have a wonderful rest of your day. Thank you.